Hello, and welcome to this recorded session for the 2026 Southeast Cardiovascular CT Workshop. My name is Shalmali Dharmadikari. I'm a physicist at Emory, and today I'll be presenting Photon Counting CT, the next leap in cardiac imaging. This talk will highlight how advances in CT physics, particularly photon counting CT, are directly improving cardiovascular imaging and clinical decision making. Cardiac CT is one of the most demanding imaging problems in all of radiology. You need high temporal resolution to freeze cardiac motion, sub-millimeter spatial resolution to see coronary detail, wide coverage for the whole heart, and ideally want to keep doses low. So these four demands are constantly in tension with each other. Existing CT systems use energy integrating detectors, hereon referred to as EIDs. Innovations in the past few decades have made smart engineering trade-offs, but the detector technology itself has been the limiting factor. The conventional EID systems currently meet only some of the desired requirements. For example, dual source systems have high temporal resolution about 66 milliseconds. Then there are wide detector CT systems like the 320 slice coverage, which enables broad anatomical coverage. There's one beat imaging where it can capture the whole heart and its function in one heartbeat. Even on the best of the MDCT systems, the spatial resolution is currently limited to zero point 0.3 to zero point 0.5 millimeters. Cardiac CT with EID has a few challenges, including spatial resolution, artifact susceptibility, and radiation exposure. Imaging small coronary artery vessels with CT angiography is currently limited due to spatial resolution of clinical scanners using EID. Calcium blooming is an artifact that's produced by calcified plaque in coronary CTA. In conventional EID, high attenuation structures like calcium cause strong signals that spreads into adjacent pixels during the integration process, and this partial volume artifact causes what's called blooming. As a result, the calcium appears larger than it is, and this can be a significant contributor to false positive results, resulting in an overestimation of stenosis. So, for patients who have a high calcium score, blooming artifacts cause stenosis measurement inaccuracies. As shown in this paper, the top image is a coronary CT angiography which shows a calcified section of coronary artery lesion and can be interpreted as severe stenosis. However, as revealed later in IR angiography, the stenosis was less severe. Coronary stent evaluation on coronary CT angiography is challenging because metal artifacts and blooming affect the measurements, exaggerating the stent size, causing apparent luminal narrowing and reducing intraluminal details. These effects can be worse in small stents, often making studies non diagnostic. So, image quality is best in larger, thin stents while making case selection important. Clinically, coronary CT angiography can overestimate in stent restenosis, as in this case, where CCTA suggested significant ISR but angiography showed only mild narrowing, highlighting the limited reliability post PCI. CT angiography classifies plaques as calcified, non-calcified, or mixed. The calcified plaques are typically over 220 Hounsfield units with more than 50% calcium, with dense calcium being classified over 350 Hounsfield units. And low attenuation plaque ranges between 30 to 75, but it varies with contrast levels. Since attenuation depends on the luminal enhancement, fixed Hounsfield cutoffs are unreliable, and so guidelines favor scan-specific thresholds. CT detects calcium well, but it struggles to distinguish lipid-rich from fibrous plaque, and it cannot assess fibrous cap thickness. Newer methods like spectral CT may help, but current Hounsfield-based characterization remains limited, with plaque measurements highly sensitive to threshold selection. For example, results from this study show plaque composition varies depending on the Hounsfield threshold used, and changing the threshold significantly affects the measured LAB volumes, highlighting the variability and current limitations. So, what is photon counting CT and how does it differ from EID? Conventional EID detectors use an indirect detection process. So, an incoming X ray photon first strikes a centimeter material, which converts the X rays into visible light. That light is then detected by a photodiode, which converts it into electrical signals. There are multiple steps in the signal chain, X ray to light conversion to electrical current. At each step, there's signal loss and added noise, which degrades image quality and limits spatial and contrast resolution. There is also a light spread within the scintillator, and which reduces the spatial precision, contributing to blurring and blooming artifacts. In contrast, the photon counting detectors are direct conversion systems. So, materials like cadmium telluride, which is used in the Siemens Neotome systems, or deep silicon, which is used in newer GE system, they directly absorb the X ray photons, and each X ray photon generates electron hole pairs in the semiconductor, producing an electrical pulse immediately. As a result, there are fewer sources of noise, much better preservation of the original signal. An additional advantage is that the photon counting detectors measure the energy of individual photons, not just their total intensity. Because each photon generates its own individual pulse, the system measures the height of the pulse, which is proportional to the photon's energy. And by setting energy thresholds, the detector can sort incoming photons into energy bins. So, this is energy discrimination by thresholding. To the major consequences here. First, you can reject the low energy electronic noise pulses that fall below the lowest threshold. That's where the noise reduction comes from. Second, you can now have energy resolved data from every scan automatically without any special protocols. So, by binning the photons according to their energies, electronic noise can be rejected and spectral imaging at the detector level is achieved, improving tissue characterization and material differentiation. So, overall, this shift from indirect to direct results in higher spatial resolution, reduced electronic noise, and improved contrast resolution. In photon counting CT, every acquisition is inherently spectral. So, we can reconstruct monoenergetic images at virtually any KeV level after the scan. Clinically, this is very useful. Low KeV images enhance iodine contrast, improving visualization of vessels and perfusion, whereas higher KeV images help reduce artifacts like blooming and beam hardening, particularly in the presence of calcium and stents. Beyond that, spectral data enables material decomposition, which means we can mathematically separate different tissue components like iodine, calcium, fat, and water. This works because each material has a unique attenuation profile across different energy levels, like a spectral fingerprint. And that opens the door to advanced applications like iodine maps for assessing perfusion, calcium subtraction for better lumen evaluation, etc. Importantly, this capability is built into every scanner with photon counting CT. On conventional systems, similar information requires dual energy acquisitions, which involve separate scan specialized protocols and could come with an increased radiation dose or workflow complexity. But with photon counting CT, there's no need for special acquisition mode. You get the spectral information by default every time. So overall, this represents a shift from optimal spectral imaging to routine, always available spectral data, which significantly expands both flexibility and clinical utility. So why does this technology matter? It comes down to one thing: better information for better decisions. You get improved image quality, so with high contrast to noise ratio and fewer artifacts, spectral information, higher spatial resolution. Also, achieving equivalent or superior image quality at a fraction of the radiation dose, which has major implications for pediatric imaging, cardiac imaging, oncology follow ups, and screenings, and reducing the amount of iodinated contrast that's needed, which improves safety for patients with renal impairment or contrast allergies and lowers the overall procedure cost. Now, let's look at the role of photon counting CT in cardiac imaging as we discussed the advantages earlier. A major application of photon counting CT is in coronary CT angiography for visualization of the vessel lumen in the presence of calcium and stents. In conventional CT, calcified plaques often appear larger because of blooming, which leads to overestimation of stenosis, particularly when there is high coronary calcium. To achieve confident lumen evaluation, reducing or removing the calcium signal while preserving contrast enhanced lumen is key, and that can be achieved with spectral CT. So the example that's shown on the right side is a heart transplant patient imaged with conventional CT that reported 50 to 69% stenosis. But on photon counting CT with thinner slice and improved resolution, the lesion was downgraded to 25 to 50%. On the left side, you see that on the EID CT, the proximal LAD shows a small calcification. On photon counting CT, it appears as a mixed plaque with surrounding non-calcified tissue. The RCA is normal on photon counting CT, but for EID CT, it shows non-calcified plaque in the proximal segment. So, by reducing blooming and improving the lumen visualization, photon counting CT can prevent overestimation of disease, avoiding unnecessary invasive catheterization while increasing the diagnostic confidence. Another example here, which shows virtual removal of calcium in a severely calcified artery, allowing for better lumen evaluation. Atherosclerotic plaque is not all the same. In the composition of plaque, whether it's calcified, lipid-rich, or fibrous, it determines its vulnerability to rupture and its risk of causing a major cardiac or cerebrovascular event. Conventional CT can identify calcium, but it struggles to reliably characterize soft plaque components, especially when different tissues have overlapping attenuation or when heavy calcium scores causes blooming. On the other hand, photon counting enables true material differentiation with a single scan, allowing us to distinguish lipid core, fibrous tissue, calcium, and even intraplaque hemorrhage, which would otherwise require intravascular imaging. So, photon counting CD significantly reduces calcium blooming, improving lumen visualization and stenosis assessment in heavily calcified vessels. Together, this supports more accurate risk stratification, helping identify patients who truly need aggressive intervention versus those who can be managed medically, potentially reducing the need for invasive procedures. Plaque burden is the strongest predictor of cardiovascular risk, so accurate plaque quantification is critical. In this study on the left, you see conventional energy integrating CT shows a particularly partially calcified plaque, but calcium causes partial volume averaging, obscuring the non calcified components, particularly the LAP. On the right, photon counting CT significantly reduces this artifact, allowing clearer separation of calcified and non calcified plaque. While the total calcified volume appears similar, this reflects the fibrotic tissue being more accurately classified as calcium with photon counting CT. Overall, photon counting provides more reliable plaque composition assessment, which is essential for risk stratification beyond luminal narrowing. One of the most important capabilities of spectral CT is its ability to leverage the energy dependent absorption of iodinated contrast to generate myocardial iodine map. Because myocardial iodine concentration can serve as a surrogate for myocardial perfusion, these maps allow voxel level quantification of myocardial blood supply. The iodine distribution is typically displayed as a color coded map across AHA myocardial segments, from which metrics like normalized attenuation, tissue perfusion ratio can be derived. So, in this study, we see a patient undergoing cardiac CT for coronary artery disease. Across all the panels, the arrowheads highlight a clear perfusion delay in the lateral wall of the left ventricle, consistent with chronic left ventricular ischemia. Figure C illustrates the color coded iodine map, and this shows how spectral photon counting CT enables non invasive, quantitative myocardial perfusion assessment within a single exam. Using the spectral information from photon counting CT, we can also generate images that are equivalent to a non contrast coronary calcium score scan without performing an additional acquisition. For example, in Siemens, using the quantum pure calcium algorithm, you can effectively remove the iodine signal, enabling accurate Agassiz score estimation directly from contrast enhanced scans. These calcium scores show a strong correlation with conventional 120 kV non contrast scans, confirming the reliable iodine subtraction. And so, by eliminating the dedicated non contrast scans, photon counting enables meaningful workflow gains in, including reduced scan time, lower radiation dose. In addition, photon counting significantly reduces the calcium blooming, allowing for more accurate calcium quantification and improving overall confidence in the coronary calcium assessment. Conventional CT is also limited for stent evaluation because of low spatial resolution and artifacts like blooming, beam hardening, etc. Photon counting CT improves spatial resolution, reduces blooming, and provides more accurate stent and lumen measurements. In this study, we see a dual source ultra high resolution photon counting CT in a patient evaluated for suspected obstructive coronary artery disease. In panel A, calcifications are visible in the circumflex coronary artery but without significant stenosis. This finding is later confirmed by invasive angiography. And in panel B and C, a stent in the left anterior descending artery is shown. So, photon counting CT clearly demonstrates calcification external to the stent, which is compressing the in-stent lumen. A suspected mid-lat stenosis can be appreciated with improved confidence due to the high spatial resolution and reduced blooming artifacts. Photon counting CT shows how better physics translates into better care. By improving image quality and diagnostic confidence, photon counting CT reduces unnecessary invasive procedures and enables more precise, personalized treatment decisions. That's the real clinical impact of this technology. Of course, it's important to acknowledge the current limitations of photon counting CT in cardiology. So, at present, availability remains limited with photon counting CT systems concentrated in select centers. There is also a higher upfront cost compared with conventional CT technology, which affects broader adoption. In addition, while early diagnostic results are very promising, we still need large scale outcome data to fully establish how these imaging advances translate into long term clinical benefit. That said, as access expands and evidence continues to mature, photon counting CT has strong potential to become an integral part of routine cardiovascular imaging. Thank you very much.